Exploratory Laparotomy by Michelle Jenkins. Exploratory laparotomy surgery opens up the abdomen area. This surgery is done to find the cause of the problem. Patients who complain of abdomen pain with no known origin, and for those who sustain traumatic injury to the abdomen. Its main purpose is to determine the origin of pain and other symptoms. For this procedure, a large incision is made to explore the entire abdomen cavity to find the source of the problem. The surgeon can identify the problem and any necessary treatment can be placed. With the large incision, the surgeon can see and check the organs inside, such as the large and small intestine, gallbladder, and kidneys, and more. Patients will be instructed on how to prepare for his or her surgery. The patient should not eat or drink for 8 to 12 hours before surgery in order to avoid aspiration or vomiting. Patients will be instructed to stop medications which may increase your risk of bleeding during surgery. All patients should avoid alcohol and smoking weeks prior to surgery. Instruments for an exploratory laparotomy should include a major instrument set, handheld and self-retaining retractors. The large self-retaining retractor, such as Baltimore retractor, helps open and holds the incision in the abdomen. Some other instruments used in exploratory laparotomy are hemostats, Adson forceps, Babcocks, Alice clamps, Mayo and Met scissors, DeBakey forceps, needle drivers, pull suction, and different types of retractors. Many of these instruments are in sets of tubes in different sizes. In the operating room, there should be surgical lights, anesthesia equipment, and monitors that are near the head of the patient. The operating room also contains an IV pull, a back table for instrument sets, Mayo stand for more commonly used instruments, and a basin stand. The operating room should also contain an electrical surgical unit, Neptune, and a patient's bed. All the instruments and devices required by the anesthesiologist should be placed close to the head of the patient. The electrical cautery unit should be placed at the foot of the patient's bed. The Mayo stand is positioned over the patient's lower extremities and comes in from non-operated side. The back table is placed near the Mayo stand. The back table is a large movable table that is covered with drapes for placement for sterile instruments, supplies, and equipment for surgical procedure. The instrument set is placed on the back table where the ring instruments are placed on a roll towel in front of it. The Mayo stand should be covered with sterile drapes on which instruments that are most frequently used, such as Mayo, Met scissors, hemostats, Cokers, Babcocks, Alice clamps, are all placed on the Mayo stand. For exploratory laparotomy procedure, general anesthesia is usually given for this procedure. The anesthesiologist places a mask over the patient's mouth and nose. Anesthesiologist usually delivers the anesthesia medication through an IV, such as propofine. The anesthesiologist monitors you continuously while you are asleep. The anesthesiologist will monitor the patient's blood pressure, heart rate, breathing, and other vital signs to ensure they are normal and steady while the patient remains unconscious. After the procedure, the patient may have some pain or discomfort. The patient may be prescribed narcotics for pain relief. Medication generally recommended: take over-the-counter medication such as Tylenol, ibuprofen, Advil, Motrin, or Aleve. Patient skin preparation is important for preventing surgical site infection. The patient is prepped with an iodine solution starting at the surgical site, moving outwards in a circular motion. The iodine solution spans from the nipples to the mid-thighs. Also, indwelling catheter is inserted before the procedure and could remain for a few days after. The patient is positioned in a supine with arms extended outwards at a 90-degree angle. Before starting the procedure, a timeout is performed. During the timeout, the entire operating team reviews the patient identity, the procedure, and the surgical site before surgical incision or the start of the procedure. The surgeon will need a number 10 blade and a number 15 blade. The surgeon uses the number 10 blade to make the incision a few inches above the patient's belly button to a few inches below. At this time, bleeding vessels will be clamped or cauterized. After the incision is open, a self-retaining retractor is often used. If the abdomen fluid is encountered, sponges, suctions, and irrigation are used. Next, the organ and tissues will be inspected for underlying issues. At this time, any necessary treatment can be placed right away. When the procedure is done, the incision is closed with sutures or staples. A continuous suture method is used. Each layer will be closed until the first layer is closed. The type of sutures depend on the surgical's preference. Once the incision line is sutured or stapled closed, the surgeon will ensure the incision area is clean. Depending on the surgeon's preference, a sterile surgical bandage will then cover the final incision. After the procedure, the patient will be taken to the recovery room. As soon as the patient is awake and alert, the patient will need to be walking around as soon as possible. This will help prevent blood clots. The patient may not be able to eat solid foods for a few hours after the surgery. The incision site should be kept clean and the dressing should be changed regularly. Like any surgical procedure, there can be complications during and after a procedure. Some possible complications that could occur include incisions that do not heal properly, reaction to anesthesia, infection of the incision site, wound adhesion, and incision hernias.